The response to Flixitide is really probably reducing the severity of the symptoms by about 40 to 60%. That's what the studies would say. The younger you are in general, the less well you respond to inhalers. That's a fairly clear pattern. The other thing to be clear about is treating young children with inhaled steroids is symptomatic treatment. You're not altering the course of the disease. We used to think many years ago that if we got in really early with decent doses of inhaled steroids that you could prevent airway remodeling, but that's been shown not to be the case. So we're only really managing the symptoms. We're not trying to alter the course of the disease. There are other efforts to do that, which is probably beyond the scope of this talk.
John, can I ask, so we jumped in with Max with Montelukast that probably a year into his involvement in our service. Do you think that was reasonable given what you know about the history? And because I would tend to maybe build on Montelukast if I wasn't getting a response, maybe even somebody younger, and obviously he had allergic rhinitis, but that was that too early?
No, I think Montelukast is a very useful drug. It's very clear in Montelukast that it's very the pharmacogenetics are very important, meaning that there are people who have certain not mutations, what's the word I'm thinking of? Variations in their genome that predict whether or not they're going to respond to Montelukast. It is the advantages of Montelukast, of course, are that it's a tablet, so you don't have to. There's no inhaler technique to worry about. It only has to be taken once a day, of course, which is also an advantage, and it doesn't have those steroid side effects which a lot of parents worry about. Although are fairly low, the risk of side effects is very low at low dose inhaled steroids. There are obviously some well-publicized side effects of Montelukast, including one of them is night terrors, and the other one is behavioural change. It's very difficult in preschoolers, of course, to assign to having preschoolers at home myself. Their behaviour does tend to vary.
What's the terrible twos and what's the Montelukast? From
minute to minute. But there have been definitely over the last, I don't know, 20 years, there's been definite cases that I've had where it was pretty clear we stopped it, it went away, we started it, it came back. But very, very, I'm talking about less than 5 cases. It's a side effect that's been reported a lot more now than it was, say, 10 years ago. Possibly that's due to people being aware of it. But I would argue that Montelukast is still a very safe medication, and it's effective in some children. But again, it's about the trial treatment. So if you do the trial treatment and there's no clear effect, then you stop it and start something else. What you shouldn't do is add something else, and that's a general rule in asthma. In fact, and it's one we don't follow as well as we should. So we put people on combination inhalers. When they don't work, we increase the dose. That's what we shouldn't do. We should stop the LABA and increase the dose of steroid. So that would be hopefully I'll mention that again during the talk during the night, but that's a very important principle. So I think Montelukast can be very, very useful. There's one last thing to say about it, which is there was a study done in Melbourne probably about 10 years ago now, published in a pretty high impact journal, and it was using Montelukast as to treat each episode. So they recruited a few hundred kids, and they randomized each episode to Montelukast or placebo, and they showed a decrease in healthcare utilization in this age group. It wasn't a massive impact, But one thing that what I found quite useful is it enables you to give kids something that's not an oral steroid. Because one thing I can tell you is that giving kids multiple courses of oral steroids has a huge impact. And there's definite evidence that anything more than 3 or 4 courses of oral steroids in a year, you know, impact on their brain.
Would you say that there's, like just going back to diagnosis, is there anything that you see routinely in clinic or in kids sort of sent to you, you know, perhaps with a diagnosis of asthma that on further, you know, history or further examination that, you know, really speak out to you that perhaps there's something else at play or a differential diagnosis there?
Yeah, absolutely. So I mentioned cough as being one of them. So asthma tends to cause a dry cough. It can cause a wet cough, obviously, but it tends to cause a dry cough. And kids get lots of dry coughs. If a kid has a persistent dry cough or a very recurrent dry cough, they sometimes, probably not as much as they used to, but you still get this diagnosis of asthma and you'll get a referral saying not responding to asthma medication. And any respiratory physician will tell you this. The first thing you do with an asthma referral is you try to undiagnose the asthma. And in that sort of case, in the absence of wheeze, the causes of cough very, very commonly are things like post-viral cough, which are these kids who cough for 4 to 6 weeks with every virus. You consider a kid gets 8 viruses a year at least, and you're coughing for a very long time. So the other thing is the nature of the cough. So if they do have a wet cough, and this is a common scenario where they cough and wheeze and the cough is wet. And very often these kids will have a condition called protracted bronchitis, which is sort of a condition which I think it probably used to be called wheezy bronchitis many years ago, and then it sort of disappeared, and now it's come back in fashion. And it's called protracted bronchitis. And these are these kids that have wet coughs that go on for longer than 2 to 4 weeks, and respond to oral antibiotics, although they often need a prolonged course, so for definitely greater than the usual 5 days, and sometimes for up to a month. So, and those kids often wheeze, so you can get wheeze and cough, but it's actually protracted bronchitis. The key thing there is the history of a wet cough. It's very unusual for a child with asthma or virus-induced wheeze to have a wet cough. It's usually dry.
Should we try to some questions? We're just looking at the questions. So Glenda's asked, there is confusion at present as to what infection control procedures are necessary to perform spirometry when clients are asymptomatic and not deemed to be at risk of having had contracted COVID-19. Do you guys want to talk about our current position with spirometry and what we're doing?
Yeah, it's a bit difficult at the moment. I, was doing it for a little while at the start, and then the TSANZ recommended that point of care spirometry cease, because there was that potential for aerosolization of the virus particles, even in potentially, as you say, asymptomatic people. But so we ceased it for a little while. Then they've changed their recommendation recently that it can be done, I think, in a very controlled lab environment, or if your point of care spirometer has a bacterial viral filter. Because mine doesn't, I haven't resumed spirometry testing yet, but it is being done in our respiratory function lab at the hospital. So, and then Lauren said, Dr. Widger, you mentioned predicative use for effect on Montelukast, sorry. I'm wondering if there is any tool that could be used to predict for the risk of the neuropsychiatric effects before Montelukast use.
So that's a brilliant question, and I think definitely there's a lot of work being done towards that goal. there are certainly, you can go and get your entire genome sequenced for $1,000 in Sydney, and they'll tell you the drugs that you should avoid for every condition you could think of. So, you know, it can predict your risk of side effects. Montelukast isn't quite there yet, but I'm sure that will be added to the list. What they haven't quite managed to do yet is, and what's more difficult to predict actually, is whether you will respond to those drugs. So in a few years' time, I don't know how many years, you'll be able to get a blood test. We will be doing true personalised medicine, so we will know exactly what medications, whatever the condition is, that you will respond to and the ones that you should avoid. So not quite there yet, but that is definitely quite an exciting avenue of research. In terms of the trial of treatment, you are looking for a resolution or a decrease in symptoms. So it's usually pretty obvious. As I said, the younger the kid, the 4-year-old is going to respond better probably than a 2-year-old. To a certain extent, it'll depend on, you know, if the wheeze only happens every 6 to 8 weeks, you're probably not going to be able to show a treatment response. And you can argue maybe they don't need to be on the preventer. In those sorts of cases, putting them on an intermittent dose of montelukast might be helpful depending on the severity. So if they're ending up with lots of oral steroids, you probably want to do that. If they're mild symptoms and they're just responding to Ventolin for a couple of days, you probably don't want to do that. But you're looking for, you're not going to get complete resolution, but you're looking for a definite response.
So Tiff, is there any minimum age to conduct spirometry?
Yeah, I was thinking about this one. We sort of, I mean, the idea is to trial spirometry from about 6 years of age, purely because these are the kids that start to have the coordination to actually be able to do the test. And because we do 3 trials, pre and pro SABA, we can't, it's quite a big effort for a young child. So sometimes we'll start with 6-year-olds just doing one test and not actually using it as a diagnostic tool, but just getting them familiar with the pattern of how to do it. And as they grow and get older, they start to understand the technique and coordination of it, and then we can start using it as a better diagnostic tool. So it really depends on the child, for starters, because we have some 10-year-olds that still can't do spirometry, and even some adults that can't do spirometry. So, you know, our spirometer is the type that requires a lot of effort. And for some of the kids that we see that can't do that and can't coordinate it, we'll send them to the respiratory labs because their spirometer is much easier. Yeah. So yeah, the minimum age we kind of go with is 6, but it is variable on the coordination of the child. Yeah.
And I would add, just to that, it's important to remember that lung function in most children of this age, even if they do have asthma or preschool wheeze, is normal. So if they're asymptomatic at the time. So most children, in fact, don't have a normal lung function in between their asthma episodes.
Yeah, so serial lung functions is a good idea, because you might just get them on a really good day or a really bad day, as the case may be. But yeah, practice is a good idea. The other thing to consider with age is the set of predicted values that you're using, because sometimes the set of predicted values doesn't go younger than, say, 6. So I think that's
thanks for the questions. Yeah, just keep on firing them at us, and we're just happy to keep on sort of wandering through the presentation, but stop for questions as they come up. So I think I was meant to talk about just the key features in history and physical exam, and I didn't want to labour it, but if we just go back a couple of slides and so I think just a couple more back. So history, current symptoms, and look, I won't go through all this pattern. There's this list, but I think John's already made the point that we want to know what we're dealing with is a wheeze as opposed to other respiratory noises, and I guess getting a good history around pattern, frequency, frequency and trigger of symptoms, and how long the symptoms have gone for, what treatment's been used at each point in time. And I guess if there have been hospital presentations, things like presentations requiring intensive care, retrieval, did they need prednisolone, did they go to emergency? And then things like interval symptoms we would ask about regularly. So what happens at night time, nocturnal wheeze or cough? And that may not point to asthma, it might give you a better picture of maybe sleep apnea. And what happens during play and exercise. So exertional symptoms, are they missing a lot of childcare or school? And our nurses are very good at going into the home environment, and one of our nurses is particularly good at tracking down cats, isn't she, and trying to eradicate cats from the home environment. But yeah, any triggers in the home environment that might trigger symptoms. And we've already talked about allergies and atopy and family history. Physical examination, again, I really didn't want to sort of focus on this too much, and because I'm sure you're pretty good at examining chest. I think of it from a pretty simple point of view, so I go back to ABCs and airway breathing, etc. But I guess if our nurses are going out to look at a child in the home environment and seeing if they're talking in sentences and just their general mental states, I think is really important. Looking at their chest, any chest wall deformities, a good pectus or something like that might indicate some undertreated disease. Have they got any work of breathing in an acute phase? Auscultation, obviously, I always labour to the medical students about good percussion. And upper airway examination. We're not doing a lot of upper airway examinations at the moment, are we, in the current environment from an ENT point of view. Any signs of chronic disease, so chronic lung disease, clubbing, looking at the skin of eczema, and height and weight. So are they nutrition and their growth being affected by chronic disease, such as asthma? Anything to add, John, from your point of view, with history and exam?
No, you're doing a sterling job.
Oh, thank you. Very good. Yeah. We might do this. This is from the Asthma Handbook.
This is from the Australian Asthma Handbook.
Yeah,
so just items that make, or symptoms rather, that make a diagnosis of asthma more or less likely. Yeah. Which I think we've discussed.
We might just go through the sort of differentials of the cause of wheezing in children, and again, this is a fairly long and detailed list.
The only thing that I would add actually is, I think, and this is something I teach all my students, is getting the patient to cough as part of the respiratory exam.
Yeah.
It's really important, because you'll often pick up that sort of suppurative type cough, or you might pick up a different kind of honking cough, or there's different characteristics of cough that can help you towards the diagnosis. The patient might not necessarily be coughing during the consultation, but if you get them to cough, it sometimes reveals a clue to the diagnosis.
Yeah. So these are causes of wheezing in children from up to date. I'm just thinking of other differential diagnosis that I would sort of see from a general paediatric point of view, but not just smaller kids, but I guess older kids. So things like, I guess, vocal cord dysfunction, which is listed there. I guess a lot of kids, maybe older children, teenagers, whether there's an element of anxiety that is, we would see some kids that have an element of asthma, but then there's a overlay of anxiety. Definitely.
It gives you that chest tightness,
yeah.
shortness of breath.
Yeah, definitely. And John's already covered sort of wet cough and protracted bacterial bronchitis.
And foreign body aspiration, if they're presenting to the emergency department with wheeze, I guess that comes back to history, doesn't it?
Yeah. Anything else from your perspective, John, from the differential diagnosis?
I think the only thing I would think of would be, especially in young children, the first 2 or 3 years of life, to think about the history of smoking in pregnancy, because when the smoking in pregnancy, it causes it basically causes smaller airways to develop, and you don't need your airways to be that much smaller at that age to get wheeze with the virus. So having said that, a lot of those children, if you measure their lung function in research scenarios, they've got reduced lung function compared to their age-matched peers, but they tend to catch up as they grow. provided, of course, that they, don't continue to be exposed to environmental antagonistic factors, I guess. But that's something to remember, and a lot of the time these kids do not respond to bronchodilators very much, and they probably don't really respond to inhaled steroids either. So they can be quite a difficult and challenging group of kids to manage.
Yeah. All right, shall we move on to the next case?
I think John's already spoken about that actually, just that the pathway, I guess, for diagnosis in a child over 6 is a little bit different in that you have got physical examination and history, but the added benefit of being able to perform spirometry both before and after a bronchodilator for that diagnosis. Now, I was going to ask if there were any more questions. Can I do it without getting out of this? I don't know if I can actually. It's okay.
Yeah, I think there's a couple.
How did I find it again?
Yeah,
That's
right.
right. Q&A. Retrial of treatment. Are we looking? Oh no, we've done that one. What is the minimum age a child can be given the diagnosis of asthma?
So I think that's why I try and stay away from the word, because I don't think I've been doing this for 20 years and I've yet to get anyone to tell me what asthma actually is. So I think it's much better to think about this in terms of the child who's in front of you and how you're going to manage them. So I try and tell parents when they say, is this asthma or not? I really sort of say to them, well, look, asthma is really an umbrella diagnosis. What your child has is viral-induced wheeze, or your child is wheezing because they've got small airways, or they've got malacia, or whatever it is. I try and be as sort of specific as possible, and then I explain to them why I'm giving them the medications. I hear a lot of other people in my specialty saying we shouldn't call preschool wheeze asthma, but the same people are prescribing Flixotide. So it's sort of like the conversation goes, your child doesn't have asthma, take this asthma medication. And that's confusing, I think. So I try and be as sort of informative as possible. It can take a little bit of time to explain that. But really the conversation around the minimum age is probably a bit of a moot point. I certainly think it's interesting the word bronchiolitis often gets, there's lack of agreement as to whether you can have bronchiolitis when you're 18 months. We used to think of bronchiolitis as being a disease of the first year of life, not the second year of life. So, and then, well, you have to call it something, don't you? So it's either bronchiolitis or asthma. So I think those conversations are really, I don't think we'll ever resolve them, and I think we really need to try and be, I suppose, as informative as possible with our parents and trust them to understand things. I sometimes think we try to dumb down our explanations a bit too much, but that's just my viewpoint. But there isn't, the answer to the question, there isn't really a minimum age, because it's probably not, asthma is probably not a good word to be using.
And Johnny, you're more influenced if the child is, say, an extreme prem or something. Does that? I think it does figure in my thinking a bit if they come from the neonatal unit, then more likely to maybe call it that earlier on. But I don't know if that's.
Well, you see, the question for me is the child is wheezing.
Yep.
And it's causing a problem. And the question is, why are they wheezing? And the next question is, what are you going to do about it? What you call it is less important than any of this.
Yeah. Sarah, you're up.
Okay, so just talking quickly about a slightly older patient, a 13-year-old boy who was referred to our service in 2017. He's under guardianship care, but moved to his new carers residence at that time. That's how he became involved with us. He has got a really significant history of asthma with multiple presentations to, like multiple hospitalisations and quite severe. He's been to intensive care twice and had about 7 admissions across multiple hospitals. So you would perhaps, think he had quite difficult to manage asthma, but he interestingly hasn't had any admissions to hospital since he's been in guardianship care, which was when he was about 8. So he's also got a history of allergic rhinitis, and when he came into our service, he was on Seretide, the 250 25 strength, 1 twice a day, singular. But he, having been in care and receiving his treatment, was quite well controlled actually. So we dropped him down to Seretide, the 125 strength, 1 twice a day, and continued the singular. That was ceased at a later date when he continued to have good control, but we focused a little bit more on managing his allergic rhinitis symptoms with the use of an intranasal corticosteroid spray. However, probably over the last 6 months, his lung function has deteriorated, without sort of obvious trigger, I guess, to us. He sort of developed this chronic wet cough, I guess, as well, and some sinus congestion. And so we referred him on to respiratory. He's had, to John actually, and he's had some further investigations. And we've got a slide with his chest x-ray on it actually. Have a look at.
Stuck at the moment, so because we haven't got explanatory, do we?
Oh, that's
No,
go that one.
yeah.
No, forward to.
Yeah.
There it is. So I don't know, John, whether you want to have a chat about the differentials that it sort of could be first, or just go straight to his chest x-ray and then come back.
I think it's probably worth going to the chest x-ray.
Maybe if we ask the audience what they notice in his x-ray, if we can get it back.
Yeah, I think when I saw this child that I think we have a spirometry as well, don't we? Do we have this?
Yes.
No, I don't.
I've just got some numbers. I mean, so certainly his FEV1 was 51%,
and not fully reversible.
Not reversible.
No.
Yeah.
So the spirometry question is important there, because so when you're characterizing a kid like this, you kind of think, well, what are the different aspects of this kid's disease? So he coughs and he wheezes and he's had some asthma treatment, but that doesn't mean that he may have asthma, but he also may have something else. He has his spirometry shows some reversibility, but also some fixed airway obstruction, and that's a really important piece. Now, as asthma progresses, it can do that, but it's a little bit unusual to do it in a child at this age, although it does happen. But the remarkable thing I think about this kid was he'd seen Matt before, and Matt had noticed that he'd had a wet cough, and I noticed that I think in a GP referral something about a wet cough, and then when he came to see me, when I asked him to cough during the exam, he didn't cough when I was talking to him, but when I got him on the exam table and I asked him to cough, it was moist. So you've got this fairly consistent story of a moist cough. And then you've got this did I wear the chest x-ray?
You did, yeah.
So the chest x-ray, are we asking people what they think, or?
Yeah.
I don't know how I can do that with a poll.
I might be able to comment.
You have to give them an A, B, or C answer.
Maybe normal.
Or can I not just do the comments in the question?
Yeah, maybe if you guys are submit some comments if you have got some thoughts on the X-ray in the Q&A section.
You can do like a yes, no, is this normal or not?
Yes, is this a normal X-ray?
It's a bit of a leading question.
That's a good question. Looks like there's a few comments there.
Mm.
So I did put this chest X-ray out for discussion at a radiology meeting because I think partly because I didn't agree with the way it was reported.
I can just close the presentation.
We were able to see it before, but
Yeah.
I think we have to close the presentation though.
oh, I
To
see.
do that.
Okay. Okay.
Leave it.
Okay, so we have a couple of questions coming in from our attendees tonight, so I'll just read them out to the panel, and if we can get some feedback from our panel of experts. From an anonymous attendee, is mold exposure routinely asked when taking a history within the hospital system?
Mold exposure. I don't know if you guys routinely ask. It's a sometimes observed at home visits. Yes. Yeah.
No, look, I do. But when you're thinking about an asthmatic, who's in particular, by the time they get to me, usually they're bad and they're resistant to treatment, and so it's one of the questions I ask in terms of the environment contributors. Is whether they have mold in their house, and of course mold can be difficult to see because sometimes it's in
Sometimes they don't know.
Yeah.
All of a sudden they've renovated the bathroom and the asthma gets better.
There's a in principle causation there, but I mean I have to say the literature isn't extremely conclusive, but it would certainly, I think, I tell people if they've got mold in their house and they've got asthma, they should definitely get it removed. And the problem, of course, is mold grows because of the conditions of the house. So unless you change the conditions, it'll keep growing back. But at least you can sort of keep it to a minimum. Often that conversation leads to a letter for me to write a letter to the Housing Commission to get them moved. And sometimes maybe that was the intention in the first place. But I certainly think mold is a contributor and should be asked about.
Sometimes if parents ask about humidifiers, I just mention that sort of whatever they want to do, but to make sure that the room is not so humid that they're causing mold on the walls.
Yeah.
What was their other questions? Oh, and environmental mold, I guess, is another thing. The kind of mold that grows on trees is harder to avoid.
Yeah. Thank you, Dr. Widger. Thank you, Sarah. Next question from Anonymous. Does a history of childhood asthma still exclude patients from certain occupations, for example, the Air Force?
I don't know.
I don't think it impacts as much as it used to, but it's certainly depending on the role that they're playing. I know that in the Air Force, you can't fly if you have asthma. You can't do the flight training, but it would depend on the severity of your asthma too, probably. But in police force and things like that, there wouldn't be any restrictions.
Scuba diving is probably irrelevant. I mean, I'm not sure if you're a professional scuba diver. You can be, I guess.
Yeah.
But police have divers, and so do the army, I think.
Abalone diver.
Abalone. Well, abalone divers tend to be free divers, which is also the problem.
Yeah.
But scuba diving is something that it's not an absolute contraindication, but I'd be having significant conversations with people with asthma before they go scuba diving, which I'm sure some of you will have already experienced, had those conversations, but I can't think of any other professions that would,
No.
astronauts maybe, not too many of them.
What's our next question, Melody?
Thank you. Now from Kirsty, how often would a child with asthma see their specialist if under one? In general practice, it is really hard to get them on 6 monthly care plans for regular reviews for both adults and children. They almost fall off the radar unless they need an updated asthma action plan for school. What would be your recommendations, or do you have any suggestions?
It depends. It depends on their asthma control, I would say, and how severe things have been for them. If my line to parents is that they should have a review of their asthma management at least every 6 months if they're well controlled. If they're not well controlled, it needs to be more frequent than that, and should be based around changes in treatment, I think. So if you're going to commence a treatment, you need to review it within a 4 to 8 week period. And similarly, if you're ceasing or stepping back a treatment, you need to review it in an appropriate, well, when would you say to review
No,
it?
I totally agree with you, but I think there's an implication in the question that perhaps people can't do that because they can't afford it.
Well, children would mostly be free.
The other issue, I guess, around that is that, you know, when your asthma is well controlled, it's a little bit out of sight, out of mind, and you perhaps don't prioritise it. I think in the role that we do, I've certainly come to realise, having come from a ward-based role to a community role, realising that a child's chronic illness is not their entire life, and it's not the entire life of the family. So there's, you know, parents who work and children who attend school, and it can certainly be very difficult, and quite often we can only get families to engage with us when the school is saying, we need this asthma action plan. So yeah, I don't know how, apart from emphasising the importance of asthma review for maintaining school attendance and employment, and, you know, staying well so that you can continue on with your quality of life.
Yeah, I guess, I mean, our asthma program was initially sort of targeted at kids who have recently been in hospital for an exacerbation, and I think some of the recommendations that they should have a asthma follow-up, you know, pretty soon after,
Yes.
after discharge if they have been admitted or even presented to emergency. I think our asthma program has sort of evolved to include those kids who are not necessarily coming into hospital regularly, but maybe we have made a difference to their asthma if it's just been, you know, flying under the radar, and you know, we're giving them an extra 15 to 20% of, you know, of their, you know, quality of life or asthma control. Yeah, so we are fortunate in that we are able to follow up kids, you know, relatively regularly in our clinic here, whether it's via, you know, I don't know for the practice nurses in the audience if there's, you know, capacity for, you know, for, I guess, nurse only, you know, reviews as opposed to, you know, we do joint medical. And
yeah, I suppose that's the advantage of our service, is that we can provide nurse-led care in between medical appointments or in between specialist appointments. That sometimes, you know, specialist appointments are difficult to get hold of. Sometimes, you know, they're not as readily available perhaps as, you know, nursing staff. So, and we can be a bit more flexible around family life.
Next question.
Thank you. From Glenda, I'm no expert at looking at x-rays. What are the dark marks in his diaphragm? His lungs look narrowed.
Yeah, they do. I think the dark marks, I think that's on the ones on the left. I think that's the air and the stomach. But you're right, they do look narrow, don't they? So that's hyperinflation, really. And hyperinflation, okay, so hyperinflation asthma, yeah, that makes sense. If you look, there probably is a little bit of atelectasis or a subsegmental collapse of the medial aspect of the, it's probably the medial aspect of the upper pole of the right lower lobe. Given the diaphragm also looks to be lost as it goes in towards the center on the right hand side. The airways look very thick to me. And you can almost convince yourself that there's parallel lines going out into the periphery. And parallel lines are not normal in airways. Airways narrow as they go along. They're not like train tracks. So we do call that what we call it tram tracking. And you could convince yourself, perhaps, and I'm a little away from the X-ray at the moment. I don't have great eyesight, but well, I think when I looked at this initially, I thought maybe there was some ring shadows. So that's sort of, sorry, very thankfully for the old man. So my concern here was with a history of wet cough on those changes on an X-ray as to whether this child has bronchiectasis, which is the lung damage that happens as a result of chronic infection or suppurative lung disease. So we've booked this young chap into to have a CT scan. So this is an active case, and we'll see if he does have bronchiectasis. Then there's a sort of a number of potential underlying causes which we'll look at. So cystic fibrosis would be one of those. Of course, we screen for cystic fibrosis in South Australia at birth, as we do in all states in Australia. So it's unlikely, but still possible. And there's several other things like immune deficiencies, from immotile cilia syndrome. Sometimes this happens post-infection. Sometimes it's foreign body, or the same process seems to be bilateral, so I'd say that's probably unlikely. So those are the sorts of things we would think about if this is bronchiectasis. Now, we might be wrong, it might be just inflammation and mucus plugging from asthma. But I think certainly that wet cough history is telling me that something is outside of the normal.
And John, is he definitely committed to a bronchoscopy, or you just wait and see what the CT shows?
Well, no. So bronchiectasis is diagnosed on CT.
Yeah,
The purpose of bronchoscopy is really primarily for culture.
Yeah.
And a kid this age, they should be able to cough and speak out.
Yeah.
So he doesn't necessarily need to have bronchoscopy.
Yeah.
Can we move on to the next slide?
Yeah, I'm just conscious so I can get to the other two learning objectives, because we're wandering through, but definitely, yeah. Were there any questions regarding that case? But we did. Sorry, go on, Melody. Was there?
Thank you, panel. There are a few questions remaining. However, we can get to it at another pause if you like.
Yeah, sure. I just wanted to ask, because the next why won't my thing work? The next slide was a question that was sent through before the presentation tonight. I can't get the next slide on the screen though. Oh yeah, I see. Yeah. Okay, I'm good. Which I thought might perhaps be. There we go. Was about management of asthma-like symptoms when it only occurs during exercise.
So I'm happy to talk. So obviously, so I've always loved the symptoms shortness of breath on exercise, because hands up who gets short of breath on exercise. so that's always been, I've always laughed at that. But it's a real point, because very often you get people who are short of breath on exercise, and you have to figure out, is it normal shortness of breath on exercise, or is this asthma? Or what we like to call exercise-induced bronchoconstriction. So I think, and that's what the slide that you've got in front of you is probably talking about. So what I like to ask, so this sort of happens in asthmatics and non-asthmatics. So some asthmatics will also have shortness of breath on exercise. You still have to figure out whether it's the asthma that's causing their shortness of breath, or whether Maybe they have poor conditioning. One useful question to ask is when you get short of breath, what does it feel like? And is it more difficult to breathe in or breathe out? Because of course, asthma is a disease predominantly of breathing out. The airway obstruction happens on exhalation, not on inspiration. And the other thing is to ask, are they breathing fast? Because of course with asthma, they're obstructed, so it's actually a difficulty to breathe fast. If they're breathing fast, then that's a clue. Hyperventilation happens. This is a common story. Is this sort of child, usually an older child, teenager, who's one of the risk factors for this condition is the word representative. So the child has played representative sport of some sort. Another risk factor is when the parent says, "I'm not a pushy parent." So they've been top of their sport in year 6, year 7, year 8, and then suddenly year 9, they're getting this shortness of breath on exercise. Very often, so they'll either be hyperventilating. A good question to ask is, do you feel dizzy or do you get tingling in your hands and your feet? And then the other thing that sometimes happens is they'll say they're wheezy, but when you really ask them when do you make the noise, they'll say when I'm breathing in. And then when you demonstrate the difference between a wheeze and a stridor, they'll often confirm that it was actually a stridor. And this is a condition called exercise-induced laryngeal obstruction, and the subtype of that, which is called exercise-induced paradoxical vocal cord movement, where the vocal cords, instead of opening on inspiration, close on inspiration. And that is, I wouldn't say necessarily can be put down to anxiety, but it does tend to happen in that pattern. So a very useful test in exercise-induced bronchoconstriction, where you don't know whether that's the diagnosis, is a cardiopulmonary exercise test. Having said that, if you're fairly convinced that it's asthma, then you don't need to do that. It's only when you think it might be something else. In terms of if you're happy that it is exercise-induced asthma, there's a number of things you can do. So being on the right medication, so being on the right preventer is important, and making sure they're compliant. And by the way, if you look at all the studies that have been done on compliance, and there's a good meta-analysis on this in the literature recently, the average, this is where they've gone, they've measured compliance invasively by checking up on people and spying on them, essentially. The average compliance is about 50% in children on asthma medications. That's the average. So compliance is a real issue, as I'm sure you guys all know. But so taking a regular preventer, taking a bronchodilator before the exercise is another good piece of advice. Usually 2 to 4 puffs, always through a spacer, unless you're using something like Bricanyl, which is obviously a turbohaler. Warming up and warming down, which is something that's not, which is often missed, is extremely important. Asthma often happens when they stop exercising. We find that during cardiopulmonary exercise testing, they have most of their bronchoconstriction when they get off the treadmill. Possibly because when you're running, you've got adrenaline, and adrenaline is a very good bronchodilator. And then the other thing is to think about their activity levels. So if you're unfit, you're more likely to have asthma. So because asthma is a disease of inflammation, the more exercise, the less inflammation you've got. So that's a really important point, because 20, 30, 40 years ago, asthma kids were advised not to exercise, which is exactly the wrong thing to do. So it's important to make sure that your asthma children are getting plenty of exercise and titrate the medication to enable that. rather than titrating the exercise. The type of exercise is important. So we know that asthma is more likely, we call these asthmagenic sports, more likely to happen outdoors. It's more likely to happen where there's sustained exercise or effort for more than 8 to 10 minutes. So for example, cross-country skiing is known to be asthmagenic, downhill skiing is not, because the effort for cross-country skiing is greater and for a more persistent amount of time. Swimming is considered to be an excellent sport. Famously, Dawn Fraser took up swimming because she was asthmatic. Whether that's because it's inside or some people postulate that there's the humidity just above the water that reduces the resistance to airflow. There's all sorts of theories. But swimming is considered to be a very good sport for asthmatics. That's not to say that you have to stop doing cross-country running and take up swimming, but I think it's important for people to be aware of what their triggers are so that they can act accordingly in terms of knowing when to take their insulin and when to pay attention to warming up and warming down. So those are the sorts of things. The last piece of evidence about preventing exercise-induced asthma is actually wearing a mask. But I've yet to convince anyone to do that. So perhaps something that will be put.
Should we have a look at any of the last couple of questions before we move on to adjusting medications and the stepped approach? Melanie?
That's right. We can carry on.
We might come back to that.
Yeah.
We might come back because we can't.
Yeah.
Yeah.
No, good.
So.
Questions? Yeah.
Yeah.
Oh,
here we go.
Oh, beautiful. Yeah, yeah.
Okay. How do GPs refer to your clinic? Will the PEDS referral get to you, or is there a specific clinic, and if so, what is the fax number? That's a very good question.
Oh, I'm glad that we haven't put you on.
I'll just give you my number.
That's right.
We will get to that probably a little bit later in the presentation. Yes, you can refer to the PEDS department and just write on their asthma clinic. But if you could specify whether you want them to see a paediatrician or just the asthma nurse, just the asthma nurse. Anyway, yeah, so probably specify on top of the referral and send it to PEDS. But I'll get to some referral criteria later before we get bombarded.
That was from Kylie, by the way. Thanks for that, Kylie.
Thanks for the support, Kylie.
Mary Gearan, that sounds very Irish. A drug rep told us that recent studies indicate we should not use salbutamol in a spacer for emergency asthma treatment anymore, and that Symbicort is the best treatment. Is that true? So, Mary, that is I think a misinterpretation of the latest GINA guidelines. There's definitely evidence that when you look at severe presentations of severe asthma and also asthma deaths, there's a consistent pattern of over-reliance on bronchodilators to manage your asthma. And in an effort to reduce that, especially in adults and older children from 12 years and above, they've gone away from this sort of bronchodilator PRN step one, the old step one, I guess. And they basically what they're saying is if you wheeze at all, you need to go and prevent it. Now the Symbicort thing has come out because they feel that a lot of people you shouldn't take a bronchodilator on its own. This is what the rationale is, and that you should take a preventer with that. And so that's a combination inhaler. And obviously the only combination inhaler we can use in children in that way is Symbicort. Now this, of course, well, amongst other things, leads to problems with competition law, but that's a different conversation. So it is and it isn't true. So the reality is, if you're on a preventer, a regular preventer, and you're compliant to it, you can still use your rescue Ventolin. But it's important that this is why it's important to follow these children up fairly frequently, so you can understand how often they're using their Ventolin and use that to titrate their preventer dose, while trying to, I know this is hard, ensure compliance and make sure their inhaler technique is correct. So we're not trying out to salbutamol and spacers just yet, but certainly there's a move in older children to use more preventers. The problem in preschool kids with this strategy, A, is that there's almost no evidence at all to support the use of combination inhalers. And secondly, a lot of these kids are viral-induced wheezers. Most of them are viral-induced wheezers. And most of them are very mild, so they probably wheeze for a couple of days, just need a bit of Ventolin. And it's not appropriate to put them on an inhaled steroid. So unfortunately, a lot of the time these decisions are made on big committees, and I mean big committees, in committee rooms, and very often a lot of these people are not necessarily, I know for a fact that some of the main forces behind these changes are not pediatricians. I can tell you the pediatric respiratory fraternity are not all that happy with this, but that is the guidelines as they are. So I hope, sorry, that rather long-winded answer answers your question. The next question is from Lauren. Is there a specific age that the panel members consider the dry powder inhaler device to be suitable for a child to adequately use?
What was it, when we go from using a dry powder to...
No, when would you consider it? At what age?
Probably 8, I think. They just need to be able to coordinate it. And it depends a little bit on patient preference as well. If their preference is not to use a spacer, I would consider you know, an Accuhaler or a Turbuhaler, but generally speaking, I find most kids with the dry powder don't like the taste or the residue in their mouth, and so we tend to go back to a metered dose inhaler and spacer option, but probably about from the age of 8. I think they could potentially coordinate it, but again, getting them to demonstrate to you that they can take it effectively would be a good idea.
Yeah, I definitely agree with that. Is there any evidence for magnesium supplements in asthma? That's from an anonymous attendee.
I don't think so.
Not that I'm aware of, no. Yes,
So I think this probably arises out of the use of magnesium sulfate as a bronchodilator. Yeah, I'm not really aware of any. I'm always cautious about the word any evidence, because there's lots of bad evidence, of course. But no, I don't think there's much evidence for that. And yeah,
I don't think so.
I don't think so. There's a lot of work around vitamin D and asthma. So I think that's it for all those questions.
Now, come back again in a moment. I just, I'll go through Sophia fairly quickly. We're up to the, you know, adjusting medications and the stepped approach. I will get through Sophia fairly quickly because we have talked a little bit about the stepped approach already in her age group. But basically, she's a little girl who moved from the Northern Territory at the age of 2, hadn't had really any asthma symptoms prior, but then got quite a lot of asthma symptoms on moving to South Australia. She does have a strong family history of asthma, but this poor little girl was not sleeping, you know, with nightly asthma symptoms. She was using her reliever multiple times a day, terrible exercise tolerance at childcare, and there was a little bit of, I think it was a little bit of panic perhaps, because she was so poorly controlled. What are we going to do with her? And between a couple of care providers, had been started on 3 different inhaled corticosteroids in the space of 2 weeks. So firstly, with those sort of symptoms, just at brief glance, does she qualify for a preventer? And this again is from the Australian Asthma Handbook. Preventer indication for a 1 to 5 year old. She had required an emergency department visit, and she was actually on weekly 3-day courses of oral prednisolone. So that puts her in, I don't know if you can see, anyway, the sort of moderate to severe flare-up section where regardless of her symptoms, a preventer is probably indicated. If we look at the stepped approach for her age group, whilst most children her age would only need a reliever as needed, she's kind of in that next bracket up where she needs a regular preventer, and the options at that next step up are low dose inhaled corticosteroid or montelukast. And so we start low and step up, and then as control improves, step back down again. You always want kids on the least amount of medication to control their symptoms, obviously to reduce side effects. How do you know? Do you start with a low dose inhaled corticosteroid or do you start with montelukast? The recommendation is to start with a low dose inhaled corticosteroid. However, if the child's unable to use an MDI spacer for whatever reason, or there's perhaps significant allergic rhinitis, you might consider montelukast. Or if parents express a lot, or caregivers rather, express significant concern with starting inhaled corticosteroid, which is often the case, but it is important to warn them, as John said earlier, about the potential for behavioural changes. Reassure them that it's not the majority of cases, but that it does happen from time to time, and that we would review their response to the treatment if any of these behaviours were to crop up, or significant night terrors, that we could cease it and try something else, and that those symptoms would go away. Hence the importance of setting a review time. That's just a bit of a guide. I'm sure you guys know this on, what is a low dose of inhaled corticosteroid. They're not all sort of evenly matched. So we started her on changed her rather to a single low dose inhaled corticosteroid preventer, and set a trial period. At the review, I found her symptoms hadn't actually improved that much, and I was sort of surprised in her age group. But on, I guess, a little bit of, digging, was able to uncover that the reason she was still needing 3-day courses of prednisolone every week that the parents had in their fridge was because, she's such a strong-willed 3-year-old or 2-year-old she was at the time. She's so strong-willed that in the middle of the night when she's coughing and wheezing and struggling to breathe, she just refuses to use her spacer. Like, we can hardly get her preventer into her, let alone a reliever when it's the middle of the night and she's angry, but she takes oral liquid really well. So a lot of education came around that, about side effects of multiple courses of oral corticosteroids and various strategies around, I guess, medical play and how to, learn to have a puffer and spacer. But we actually added montelukast at that point, which is a chewable tablet, to try and help with some of her symptoms while she was getting used to taking her preventer via spacer and mask. That's sort of what I wanted to say about her.
Yeah, and she has eventually gone up to a combination preventer, hasn't she? And I guess part of the reason for this case is we would sometimes see referrals where we've gone straight to a combination preventer and haven't used that sort of stepped approach.
Yeah.
So that, I think this demonstrates that this child's obviously stepped up and earned the right to eventually be on what's fairly maximal therapy, I think, for her age.
She is on fairly maximal therapy now. Yeah, she's on a combination preventer, but we have certainly stepped up through the stepped approach to get to that point. So she started on a low dose inhaled corticosteroid, then she was on a low dose inhaled corticosteroid and montelukast, and now she's on a combination therapy. But that really needs to be in consultation with a paediatrician or a respiratory specialist at that point. And we will obviously, every time we review her, try and get that down again. Doesn't mean she needs to stay on a combination forever. When we review asthma symptom control, that's what we're looking at. We're always aiming to not have daytime symptoms more than twice in a week, not needing a reliever more than twice in a week, not ever having symptoms at night time. and not being limited in your activity. So, you know, we don't want kids with asthma to have to be the one on the bench or missing out or not being able to play with their friends at lunchtime. And I don't get too caught up in partial control, because I think anything less than that is something to work on.
I think the take-home point that I would make as well is that when you're looking at adherence, actually getting parents to keep a diary of symptoms and things that they notice, because sometimes they don't actually add up how many times their child's having symptoms. And when you actually sit them down and ask them, they don't always have the ability to recall how often in the last, you know, 2-3 weeks that they've heard their child cough at night, or, you know, wake up coughing, or cough when they were running, or wheeze. Or so quite often we'll recommend them keeping a diary or notes, and there is a guide that we use. Where is that one from?
Oh, that's an excellent question. It's either the Sydney Children's or the Royal Children's Hospital that have got a daily asthma symptom diary on their website. That's quite handy.
Yeah, but they are
just Google daily asthma symptom diary.
Yeah, putting your notes, the date, the time you've noticed them coughing or wheezing, and then that when you see us next time, we can sort of add it up and see if that's actually increased more than what you thought. Yeah.
There are, of course, a number of apps as well that will do something similar, and certainly with your older asthma teenagers, I've had quite a few that like to use there. It's quite nice to sort of review their symptom diary. It really kind of tells because recall is always hard, as you say.
Yeah.
And contemporary data collection
It gives you
is much more accurate.
that visual. Actually, probably one of the best things was when a parent kept the child, or they put a tick. They had a calendar and they put ticks on the days that the child needed their reliever, and she was able to flick through the calendar, and I was able to quite clearly see over the course of a few weeks the preventer taking effect. Yeah, good. Considerations around assessing control that we've touched on a little bit are the importance of assessing adherence and technique. So I know it seems a little bit silly, but don't, I guess, step up that pyramid without checking, are they actually taking it? Because before starting this role, I probably didn't realise how poor average adherence was. But asking parents in a way that's not judgmental, I guess, saying, you know, we know a lot of people forget to take the preventers, especially when things are going well, you know, how often are you guys forgetting? Rather than, you know, so you take your preventer morning and night, they're just probably going to nod and say yes.
The other question I think which is quite useful is to ask what are the things that make it difficult for future members to take your inhaler, because it's more of a as you say, it's about not being confrontational, more of that motivational interviewing type of technique, which I'm particularly bad at, but when I remember to do that, because it can get frustrating, you know, when you're at the end of the day, it doesn't matter what medication you're prescribed, if you're not taking it, it's not going to work.
No, so yeah, I guess if you're not achieving good control with a medication that you should be achieving good control with, you have to consider, is that medication getting to the lungs where it needs to work? So is it getting there, like, are they taking it? But also, are they taking it correctly? Because if you're not using the correct device technique, you're not going to be getting the maximal amount of medication distribution in the lungs. So there is a link there to the National Asthma Council how-to videos, and you can find just about any device under the sun and a video on how to take it. So
I think our wish list for our team would be to get maybe a psychologist and a social worker, because I think there's some evidence around psychologists, you know, involvement in asthma teams and their role, and social workers certainly, you know, with our cohorts, certainly around access to medication and cost. It's a big issue for you guys, you know, when doing home visits and seeing these kids regularly, especially the ones at risk. Yeah.
Cost is an important consideration. Some inhalers can be nearly $40 an inhaler, and some kids will go through a preventer inhaler a month. And if you've got multiple children, or with preventers, or the parents are on preventers as well, multiple medications, all these costs add up. So that's worth considering as well. And I think, you know, it's been shown in studies as well to be a contributor to adherence. You know, sometimes the parents will miss out on their own medication to buy their kids preventers. Yeah, and a bit of goal setting as well, especially with the older kids. You know, do you want to go back to playing rugby? Is that a goal for you? Or yeah, something that's meaningful for them. Yeah, or meaningful for the parents. You know, in terms of missing school and missing work and things like that.
Yeah, with the young kids, you're setting up reward charts and helping them to sort of get used to their medications. With the older kids, you're trying to gain an incentive program of of do you want to go skating with your mates or do you want to be stuck home because you can't breathe? Yeah, so there's lots of different various ways that you can utilize their motivation depending on the age.
Threatening them with a sticker chart. No, I try and avoid threats, but yeah, I guess just working out what's sort of going to motivate them and understanding, as John said, understanding their barriers to remembering or filling their scripts.
I used to think I was very smart and I'd say keep a fire toothbrush. But then I discovered a lot of people don't brush their teeth.
Yeah. But also patient preference, just asking them, do you like your inhaler? Do you like your medication? Is there something you don't like about it? Often they'll have friends with asthma, you know, do you prefer their device? And just showing them what's available, I think, is worthwhile as well.
And I think we've noticed with teenagers that you quite often have to think about their image, and taking a spacer with them everywhere is not always good for their image. So then it's trying to work out a medication they can carry very discreetly so that they can maintain that.
Maintain their image.
Yeah.
Yeah, well, that's smoking.
Well,
How are we going with
few more
questions there?
Okay.
Yeah, we can read them. Yeah.
Okay, so no name on this one. For acute asthma exacerbation in emergency, Ventolin 6 pills every 3 minutes is given for children less than 6, and 12 pills for children greater than 6. Prednisolone is also given. Is this still in?
Yes, but it's 6 puffs every 20 minutes, so 3 times in an hour.
Yes, would be the burst therapy.
Would be the burst therapy, yeah. So 6 puffs with correct technique, via a spacer, 4 breaths, and shaking the MDI in between, and then 12 for an over.
Because I think we are a bit more conscious of Ventolin toxicity now, aren't we? And you know, even though some of our plans used to say, you know, give continuous Ventolin until the ambulance arrives, you know, yeah, we are more conscious of that in the emergency department and on the paediatric ward now. So.
And for the really severe exacerbations, they add in the ibuprofen as well, don't they?
That's very standard with rescue therapy. And there has been some changes with prednisolone use. So I think for a few years we were giving two per kilo straight up. I think we've gone back to 1 per kilo. That's what you're from now, John.
Yeah.
And we're a bit less rigid with our length of treatment with prednisolone, especially with those younger kids who might be in that preschool age, may not even get prednisolone now.
Yes.
Second question. So why was Intal chromoglycate removed as one of the first line preventers?
Is that the one that tastes terrible?
Is that the one you have to pierce? It's like a spin halo, isn't it? Who's that? Yeah. The simple reason is because they're not very effective. They were people liked them because they weren't steroids. They didn't have too much side effects, but there's an old saying, if a drug doesn't have side effects, it's called placebo. So yeah, the main reason they are removed is because they don't really work. And then the next question is, are LAMAs used in this age group? So I think you're talking about, that's from Joe Melville Smith. I'm not sure which, if it's preschool age group. LAMAs are rarely used in preschoolers, although we just present a case where there was one. LAMAs are starting to creep into practice in older children, and there's some evidence that might be useful. So, but not in younger kids, not in preschool.
I think the license for llamas is in 12 and above, so my memory serves me. So llamas from 6 and above predominantly, and llama, long-acting muscarinic antagonists, LABA standing for long-acting beta agonists. Long-acting beta agonists from 6, long-acting muscarinic antagonists from 12. Another one. It works well with atopic asthma. I'm going to take that as a statement. The magnetic red P plate The magnetic red P plate used for driving on a mirror or a fridge is a good prompt or reminder for puffer or pills. I saw that one.
Okay. Yeah.
Something that they see. Sometimes they say put a sign on the back of the toilet door, or if you go to the fridge for breakfast every morning and the fridge for dinner every evening, have a sign on the fridge or the back of the front door before you walk out to get in the car to go to school.
Or quite often I'll say set an alarm on your phone, because so many teenagers and kids have phones now.
Set alarms and do not turn them off until you've taken your preventer.
All right. So I might get on to the next. I think there was a previous question submitted that again for you, John, I think around the mismatch between recorded symptoms and spirometry. That's the next case, isn't it?
Yes. Yeah, it came through from the community. So it was a case study of a 7-year-old who had a diagnosis of asthma, wasn't reporting any current asthma symptoms. However, that's what their lung function looked like pre-treatment. Do you want me to show you the post-treatment? Are you ready?
I'm excited.
Yeah.
I'm going to pretend you haven't tried this before. So, yeah, look, there's a number. This is something that I've seen a few times. My most dramatic one was my teenager when I worked in Sydney, who had lung function in the 40s with no symptoms. And had normal CT, we investigated it pretty extensively and couldn't find anything else. So there's a sort of an old adage in medicine: we shouldn't treat the test. Of course, that's not, there's some tests you should treat, but you may decide if someone's asymptomatic that you should, the purpose of treating asthma is to improve the quality of life, then why would you treat someone who's not having any symptoms? The counter argument to that, I guess, is if, first of all, if we know that if you've got significant obstruction with reversibility, you're at increased risk of having an asthma attack, so there's risk mitigation. And secondly, we know that airway remodeling does happen over years. And while treating young preschoolers who mostly don't have abnormal lung function with preventers doesn't probably affect their lung function in the long term, perhaps doing it in this case may do. And we know that your lung function probably peaks in your mid to late 20s. So if you're like me, you're on the slippery slope. And if your peak isn't very high, you're going to get to the bottom of the slope much quicker. So it's about optimizing. There's also a case for optimizing lung function. I'm not so sure there's a complete right or wrong answer to this, but I certainly think that if I saw that sort of result, I would probably be recommending treatment. Now, the other side to that is convincing the person to take it, because it's hard enough to get people with symptoms to take their medication, but getting people without symptoms to take their medication is probably more of a challenge. So, yeah, I think that's probably as good an answer as I can give.
They, yeah, I have a similar patient, and I guess I've just tried to say, perhaps you just don't know how good you could feel. It's that.
Yeah, that's a good point.
Yeah. You go to you think that your eyesight is fine, and then you go to the optometrist and they trial a stronger prescription, and you think, oh wow, I can see. So yeah, sometimes it's it's almost a bit of a trust me, let's try this. And if we don't feel any better or it doesn't make any difference after 6 weeks, you know, I've lost the bet.
Yep.
Yeah. So I thought, given the time and we've got another objective, we might skip through James.
We should talk about smart therapy, Sarah, and then a few kids at risk, you know, just short little case vignettes, which leads into our sort of how our program works, and that might take us.
Yeah, I think the point of our case study with James anyway was to talk about the progression to SMART, which we touched on briefly before. It's so if you looked at the stepped approach for an older child, like a 12-year-old or adult, you'll see that that bottom step where they require a reliever alone is much smaller. The greater percentage of asthmatics in that age group would need a preventer of some description, and whether that is a low dose inhaled corticosteroid that they're compliant with morning and night, or whether that is potentially a combination of inhaled corticosteroid and long-acting beta-2 agonist. So I guess going back to what John was talking about before, that idea of not treating with a short-acting beta-2 agonist alone, actually treating symptoms and getting some prevention or some treatment at the same time. They developed SMART therapy, which is Symbicort maintenance and reliever therapy, and that in short involves the patient taking Symbicort as a morning and evening preventer, but it also means taking it as needed for relief of symptoms. And they have a slightly different asthma management plan around that. I guess, yeah, the idea is that the more often you need relief, the more inhaled corticosteroid you probably need. So it's a balance.
And it works very well for teenagers who want to go skating and don't want multiple puffers for different things.
Yes.
And go stay at their mate's house and things like that. And they don't
It's
have to worry about it.
It's not a bad one for adherence in that the LABA component kicks in quite quickly, almost as quickly as salbutamol. So they get that sense of relief when they take their preventer. It's a bit of an incentive, I suppose. If you feel different after you've taken a medication, you're probably more likely to take it. Especially if you wake up with a tight chest or you wake up with asthma symptoms, you're more likely to reach for your preventer if it gives you relief at the same time.
Yeah.
So yeah, it's one to consider perhaps for adherence in that older age group.
Yeah, absolutely.
All right, so improving asthma management for children. So we wanted to talk about, I guess, children who, you know, are benefiting from our program here, or children at risk, and if you're seeing these children in your general practice and how we can help. So you want to talk generally about children at risk, and then talk about family.
Yeah, I think so. So in terms of improving management of children with asthma in practice, I guess you guys probably only get to see children for such a short amount of time, sometimes in a consultation, that just being able to, or having some of the red flags in the back of your mind to be able to pick up kids who are at increased risk of flare-up or who are at increased risk of a life-threatening episode. So I think, as we've discussed, kids who you know, have been in intensive care, huge red flag, ever in their life if they've been in intensive care for their asthma or needed intubation. Kids who've had poor asthma control or poor lung function, or, you know, hospitalisation within the previous 12 months. Environmental exposures to like cigarette smoke, or yeah, sometimes sort of socioeconomic disadvantage, mental illness, history of you know, rapid deterioration in their condition. They're more likely to rapidly deteriorate again in the future. It's a strong predictor. Particularly high use of relievers, though, is a huge predictor of hospitalisation or severe episode.
Something you probably unearthed, you know, quite a few teenagers who have Ventolin, you know, under their pillow and just, supplement most nights.
Yeah, do you get,
you know, and are at huge risk, I think. Yeah.
Do you get asthma symptoms during the night? Yeah, but it's not a big deal. I just keep my Ventolin under the pillow. yeah, a huge red flag. We know from research that if you use 3 or more canisters in a year of Ventolin, that you are at increased risk of flare-up. And if you use more than 12, you have a much higher associated risk of death. So I guess part of that is that you are relieving your symptoms without treating the underlying inflammation, potentially, or not adequately treating the underlying inflammation.
And I think this group of risk factors is probably the group of kids that we most want to see and most want in our service, so that we can try and work through a lot of these issues with them. We'll talk about the case. So Daniel is a patient that we currently see. He's an 8-year-old, and he's got a significant history. Moved from a sort of rural area to our outer metro area. His mum is a single disabled lady. She's also a smoker, and there's a history of the family violence and financial stresses there. So he also has been recently diagnosed in the last, I think, year with ASD and some social implications with that. And he is one of our severe asthmatics. He's been admitted to the wards of different hospitals, but mostly ours, 33 times. And 2 times he's been in ICU with that. So basically when he got referred to our service, we knew that he was probably someone we needed to watch very closely. And so we sort of worked through and coordinated his care between all of the specialists that we have in our service. And he was seen by our paediatric team, and many follow-up appointments later. He's basically been commenced on Sympacort and Singulair and azithromycin recently. That was only this year, wasn't it? The azithromycin.
So he did have a bad bronchoscopy and a sort of clear out of some chronic chest X-ray changes late last year. And he's still had a number of admissions already this year, and has been quite dependent on oral prednisolone.
Yeah.
But
he's had multiple courses of prednisolone, and
slow weaning courses. But azithromycin's only recently.
Yeah. This is one that we've been able to support very closely with a lot of nurse-led follow-up in between specialist reviews, home visits and phone consultation. And, you know, his mum's got our phone number and calls when she's concerned, and we support him through support her through his exacerbations as well.
And I think, he's sort of utilising, our whole team, I guess, in terms of, you would probably see him every fortnight, wouldn't you? Probably in clinic. And
very regularly.
And when I do see him in one of our joint clinics, I'm, as a general paediatrician, I'm keen to look at his, how his autism is going, schooling, because that also can, impacts on his communication and ability to report symptoms. And sort of any other vulnerabilities with the overall picture. But then we've obviously had respiratory involved, Women's and Children's, and now John with us at Flinders taking over his respiratory care and stepping up his treatment. And he's still a work in progress, isn't he?
Yes. So I might comment on the azithromycin, because I suspect that was me. But these children are challenging. And he's pretty young to be this severe. All those, ticking all those boxes that we were talking about earlier. You can't intervene, you can't prevent. There's a few kids, unfortunately, each year that die in this country every year of asthma. And we believe that every asthma death is preventable. So the sorts of interventions that we've described here are incredibly important and probably life-saving. The azithromycin, just because people will be scratching their heads as to why he's on azithro, which is an antibiotic. There's some evidence that there's good evidence that azithromycin has anti-inflammatory properties, and we use it in conditions like cystic fibrosis quite effectively. There's also some evidence that it might have some and obviously it's an antibiotic, but it also has some antiviral properties perhaps. There's been some trials, not all of them agree with each other, showing that it can decrease asthma exacerbations. Now, it is an antibiotic, and there's an issue with antimicrobial stewardship and antibiotic pressure, especially with azithromycin, because it's one of the treatments for a bug called Mycobacterium tuberculosis, non-tuberculous bacterium, sorry. And we don't want resistance in the community. So I wouldn't be handing it out sort of like lolly water, but in these sort of difficult specific cases, it has its uses.
Thanks, John.
Thank you. We might skip Ava. She's sort of a similar.
Yeah, well, just to comment. I mean, she's a teenager, and so we do have several sort of teenagers, where compliance is an issue, and without going to the whole case, she's a girl who's probably got some coexisting anxiety, and has daily SABA use, daily Benzoin use, and she came to us after a significant exacerbation, needing mag sulfate and intravenous hydrocortisone, and we continue to struggle with, I guess, engaging her, and mental health's a big thing for her. Smoking, she continues to smoke, and
she's down to 6 a
Yeah,
day.
yeah. So I guess it's really another example. Yeah, another example how I guess our nurses work really hard to engage these kids, and sometimes we do end up making notifications to the child protection, to the child abuse report line around youth at risk, and so it's a challenging. I guess age group, and I guess our message to you would be really happy to work with you guys around some of these challenging teenagers who where they're not at school very much, and their quality of life is might be sort of poor, and how we can intervene as a team. So yeah.
We're hoping to set up telehealth, in fact,
well,
so that we can
combine that is a plan, that we can sort of pilot a telehealth clinic where we can link in with GPs, practice nurses, and even sort of get our respiratory consultant in for sort of brief consults, and really work as a team.
Just appearance.
Cameo. Yeah. So let's talk about our program, which we sort of alluded to before finishing up, and taking any final questions.
Yeah, so basically, as we sort of said, our program started in 2011 and is a hospital avoidance program. We're employed by Flinders Medical Centre, but we sort of work in the community with families and their local teams to try and optimise their asthma management, however that looks for them. And we do try and target those more vulnerable or more severe kids, the ones that we talked about with the red flags.
Yeah. We try to prioritise them, but obviously we still see a fair number of kids in that middle group, and I guess we're hoping to not let them get to the point where they're severe. So sometimes that's a better point to start, but it's a work in progress.
Yeah.
I had a couple of thoughts about sort of improving service in community practice, and we do have now a spirometry course or spirometry learning module that's available for GP practices now through the Chandler's Hill Surgery website. The website's up the top there, and then if you've got any queries, the email address is in lime green just there. Spirometry in practice is a really good idea for diagnostic, but also for monitoring response to treatment. And general asthma reviews as well, but it's really important that it's done correctly by people who are trained to do it. Yeah, thank you. Other helpful resources are obviously the Australian Asthma Handbook, Severe Asthma Toolkit, the National Asthma Council, particularly their how-to videos about how to use different devices. They've got asthma action plans on there as well. Asthma Australia. And they have a referral service as well, actually. So that website, and then the following steps, and they they've got like a hotline that patients and families can call. They've got a coach program for people over the age of 12, but they will provide phone support and education. Asking for kids who've got allergies as well. I often use their parent handouts for things on like allergen minimisation, reducing, dust load around the house, and tips for reducing pollen exposure and things like that. The link between asthma and allergic rhinitis.
And you guys do concurrent clinics with our allergy specialists too. So for those of you in our catchment area, that's it's a fairly seamless service with with our asthma nurses and our allergy specialists too.
We do, yeah, we do. So we would. Do we need to talk about referral?
Just briefly, around referrals, or are there any final questions?
Okay, probably everyone's left.
That's funny, that's what I was mindful too.
Oh, it's like crickets. So we are certainly happy to take referrals from the community. You can either send them through to the paediatric outpatient clinic, is probably the best, and just specify that it's for the asthma service. You can either write, asthma nurses, or if you think that the child also needs to see a paediatrician, please just specify Dr. Matthew Scholar or Dr. Brian Coppin, or one of our paediatricians that work for the asthma service.
Or direct referrals to John.
Are you taking direct?
Oh, no, I'm happy to take
Okay.
no problem.
Absolutely.
Very happy.
Within the silent catchment though, would be great.
Yeah, so we've got hub clinics at Aldinga and Noarlunga, both nurse and nurse medical clinics, and then if you're at Marion, with the allergy team, so we're throughout the catchment area.
And we try to we try not to see just children who need education, because Asthma Australia do have amazing education ability. So it's more of a management, and it's a multi-D management.
I guess it would be hard, I guess, in GP clinics, when you've got set appointment times and things, and that's where probably practice nurses would be absolutely invaluable.
What about so you've got counterparts in the central Adelaide area and also Northern Health Network too. So there are asthma.
There was an asthma pilot, at the Northern Adelaide Local Health Network, but I don't know if that's continued funding. But there's certainly a paediatric respiratory nurse at the Women's and Children's that we work very closely with.
All right. We might wrap it up there, I think.
Thanks, everyone.
Thanks for listening.
Thanks for listening.
There's a round of applause from you.
That's right,
Okay, so that concludes tonight's session. Thank you to our panellists for this very informative education session. We hope everyone found it valuable and relevant to your practice. A reminder that when you leave this webinar, you will be prompted to complete a brief evaluation. Please take the time to do this, as your responses will help us to improve future education sessions. SATMEA have a number of education sessions coming up, so don't forget to sign up to our newsletter or visit our website to see what's on offer. Thank you for your attendance, and good night.